Okay, well, I'd like to introduce myself to the group. My name is Rod Quilitz, and I'm a clinical pharmacist and I'm the clinical pharmacy coordinator for infectious disease and the antimicrobial stewardship program at H. Lee Moffitt Cancer Center in Tampa, Florida. Today I'm going to be talking about our antifungal prophylactic options in the oncology patient. Okay, no conflicts of interest to disclose. All right, so I originally gave this presentation to a group of hematology oncology pharmacists, but I think it's a topic that, as ID specialists, is also of value to us, especially when you find yourself working in this patient population. So here's just an example case of a 29-year-old patient with stage 2 bulky Hodgkin's lymphoma, relapsed 18 months after treatment with Stanford 5 regimen. This patient's receiving ICE, ifosfamide carboplatin etoposide salvage chemotherapy with an intent to collect stem cells to take this guy to an autologous stem cell transplant after they get in complete remission. Patient medical and social history, some tobacco use, a patient's asplenic, and the patient has a history of severe esophageal candidiasis following a Stanford 5 chemotherapy. Our pre-laboratory lab work shows that the patient is not neutropenic, although he will become neutropenic following this chemotherapy we're about to give him. Normal renal function. He does have a mildly elevated bilirubin and alkaline phosphatase, no transaminitis. So they're asking you, what kind of preventative antifungal therapy should we give this patient? Okay, and there are a wide range from the sublime to the ridiculous in terms of antifungal prophylaxis that we could consider for the cancer patient. You know, certainly one option might be to just not give this patient any antifungal prophylaxis and just ask the patient to call us if he develops thrush or oropharyngeal discomfort, or give fluconazole prophylactically, or itraconazole, posaconazole, voriconazole, or some of the less practical things like micafungin or liposomal amphotericin B intravenous prophylactic regimens. We'll talk about where I'm certainly not going to be using 5, 6, or 7 in this patient, but we may talk about situations where it may actually make sense to use those kind of regimens. Okay, so basically the idea is we're going to compare and contrast our various antifungal options for prophylactic therapy and identify the most appropriate antifungal agent for prophylaxis for given patient populations. Okay, so first off, why should we consider giving prophylactic antifungal drugs to cancer patients? To select cancer patients, mind you, right? Obviously, we want to prevent, we would like to prevent some of these nuisance infections like thrush, but we also, so with the mucocutaneous infections, oral, esophageal, or vaginal candidiasis can be bothersome to our patient. Certainly, oral thrush is a nuisance. Esophageal candidiasis has substantial morbidity associated with it. Major quality of life impact there, especially in a severe case like the one that I put in my slide. In high-risk patients, we want to prevent candidemia and invasive candidiasis. And it's important, this is critical because in say, a very high-risk patient population like stem cell transplant or solid organ for that matter, there's roughly a 24% attributable mortality to candidemia and invasive candidiasis. And we talked about higher and higher risk patients. Now we started talking about whether we should be trying to prevent yeast infections. Now we're talking about should we be trying to prevent mold infections and which patients we should. Because we want to prevent these kinds of pictures from happening to our patients, right? So we want to, these patients with prolonged neutropenia and or lymphopenia, you know, there may be as much as a 40% attributable mortality associated with this, depending on the patient population. And, you know, so things like the invasive pulmonary aspergillosis, you see that first slide there with the classic halo sign. You have your classic air crescent sign there in the middle, which is a late sign versus the early sign of the halo. Or you have a really sad case where the patient develops CNS aspergillosis. Okay. Obviously, though, there are downsides to prophylaxing, and major one for us is, you know, in terms of should we're trying to benefit the patient, we want to do no harm in the process. we have to think about the toxicity of these drugs, right? And it's not necessarily insignificant. Hepatotoxicity is a concern for the azoles. Also, you can see it with lipid formulations of amphotericin B, and it's been reported with the echinocandins as well. Nephrotoxicity and electrolyte wastings with our polyene antifungals, amphotericin B. Infusion-related reactions, predominantly amphotericin B. QTC prolongation. So all the azoles can cause QTC prolongation, which if a patient already is prolonged may increase their risk of torsades. Also, though, if we give an amphotericin formulation to these patients, we may cause them to have hypokalemia, hypomagnesemia from our therapy, which is going to aggravate QTC prolongation. Visuals or CNS side effects, classically with voriconazole. Dermatological side effects, predominantly with the azoles, voriconazole in particular. And also there are a number of drug interactions with both maintenance medications and chemotherapeutic agents. I'll talk a little bit more in depth about the chemotherapy drug interactions when I hit voriconazole and posaconazole. Also, of course, we're concerned about resistance. If we give every cancer patient fluconazole, indefinitely, we may prevent some thrush, but we're going to develop, fluconazole-resistant Candida albicans. It just stands to reason. And also, there's cost associated with our prophylactic regimens. Certainly, in terms of which patients are at greatest risk for the more serious invasive fungal infections, it's going to be a matter of largely of two major parameters, right? Our patients who are prolonged neutropenic and our patients who are severely lymphopenic. Okay, so I'm going to focus in on some of the more common and a couple of the less common antifungal options that we have available to us. I'm going to talk about 4 different azoles. I'm going to talk about micafungin because amongst the echinocandins it has the most data for prophylaxis, not because they're paying me. And I'm going to talk about amphotericin B formulations, both conventional amphotericin B and liposomal amphotericin B. When we think about prophylaxis, it's important to think about the spectrum of our antifungal agents. So what infections are we trying to prevent, and so which agents will have which effects? And I think there's a lot of confusion about antifungal spectrum amongst our colleagues, and certainly some of our oncology colleagues. I think everyone knows that Candida albicans is basically usually susceptible to all the above, and it's the most common yeast you have to worry about until you enter a cancer center where everybody and their brother's on fluconazole, and now we're going to start seeing some of the less common, more azole-resistant yeasts. But we also get into a problem of people assuming that if it's not Candida albicans, that it's got to be fluconazole-resistant. And clearly that's not true when we have tropicalis, parapsilosis, Guerramundi, that are very fluconazole, azole sensitive. And really, of course, it's our Candida galbradas they like to produce efflux pumps that may develop either maybe sensitive dose dependent, where we have to ramp up our fluconazole dose up to 800 milligrams, or we may be, which can also cause cross resistance with the other azoles, or whether we're talking about Candida krusei, where fluconazole has can't bind to its target enzyme. However, voriconazole usually maintains its activity. And the echinocandins, of course, are great anti-Candida drugs, although parapsilosis and Guerramundi have a little higher MICs, and if you see a breakthrough on an echinocandin, it's generally one of those two. And, of course, amphotericin B has a wide range of activity against the yeasts, not great against Candida lusitaniae, but otherwise excellent if you're willing to accept the toxicity profile. And, of course, aspergillus, we lose fluconazole, and we're looking at the extended spectrum azoles now. The echinocandins have some static activity against aspergillus, and amphotericin B is also a fungicidal option for aspergillus, except for aspergillus terreus, which is rare but used to be almost universally fatal before we had voriconazole. Then we start looking at some of the more uncommon molds you see in the prolonged neutropenics, for example, Fusarium, where we may have to use when we're treating, we may use a combination of an voriconazole and a lipid formulation of amphotericin B, Pseudosporium, where the extended spectrum azoles are our best choice. God forbid your patient gets Pseudosporium plurificans, serious infection in a neutropenic patient, because we have no great choices for that fungus. The zygomycoses, that's where we lose voriconazole, because conazole maintains activity as well as, of course, amphotericin. And then, again, also kind of rare, but the dometiaceous molds like Alternaria, Bipolaris, Curvularia, Exfolia, where the extended spectrum azoles are again, our treatment of choice. So certainly not every patient is at risk for the more exotic of these fungal infections. Okay, so I'm going to start talking about prophylactic agents. I want to talk about the azoles, because they're the mainstay for our prophylaxis. And one thing I like about this slide is it shows that fluconazole and voriconazole have substantial structural similarities, and itraconazole and posaconazole do as well. And that leads to some similarities in terms of pharmacokinetics or drug interactions that are worth mentioning. Of course, I think everyone's very familiar and comfortable with fluconazole, active against Candida, also has some activity against Cryptococcus, with reduced activity against Gallbladder and Krusei. Dose-dependent activity. For mucocutaneous, you may use a dose low as 100 milligrams a day, systemic up to 800 milligrams a day. Excellent bioavailability. It's kind of a wimpy CYP3A4 inhibitor, but that increases as you increase the dose of your fluconazole. Also, it's a 2C9 inhibitor at higher doses, and we adjust for renal dysfunction. Now, the big study that was done showing a life-saving benefit of fluconazole prophylaxis was in the stem cell transplant population, right? And this was done at Fred Hutchinson by Dr. Marr and colleagues, and they looked at autologous and allogeneic stem cell transplant patients. They gave them 400 milligrams a day of fluconazole. They started it at the same time as the conditioning chemotherapy regimen, which were mostly high-dose cyclophosphamide regimens. You have like much higher doses, high-dose cyclophosphamide in combination with busulfan or in combination with radiation, much higher doses than you would see in a setting outside of bone marrow transplant. And what they found in the allogeneic transplant patient population particularly was a dramatic survival advantage for the group that got fluconazole prophylaxis versus the group that received placebo. And actually, when you look at the data, there was definitely prevention of Candida infections, including candidemia. But there's a real valid question as to whether there was enough benefit in terms of preventing some of these infections to show the sustained years of survival benefit. And actually, some more recent theory is that while fluconazole is great in terms of preventing yeast infections in these patients, there may be another reason in terms of drug interactions. Right? These patients got high dose. They all got high dose cyclophosphamide. Fluconazole was started at the same exact time. Fluconazole interacts with high dose cyclophosphamide. It actually kind of shunts it away from the production of the more toxic metabolites. So some of this benefit may have been from modulating the toxicity of the high dose chemotherapy, and not all from the prevention of yeast. That being said, clearly antifungal prophylaxis has a role in the allogeneic stem cell transplant patient. It's just whether it's this dramatic or not is up for debate. Now, looking at other patients that are at slightly lower risk for fungal infection than the allogeneic stem cell transplant patients. So there are a number of studies, but I'm just kind of pointing out a couple of them here, like Rothstein and all. They looked at fluconazole 400 milligrams a day versus placebo for acute leukemics or autologous stem cell transplant patients, right? And what they found that it reduced superficial fungal infections, as you would expect. The incidence dropped down to 7% versus 18%. And it reduced definitive and probable invasive fungal infections. They had 9 versus 32. And they had fewer deaths from invasive fungal infections, 1 out of 13 versus 6 out of 15. So it showed a benefit. particularly in the acute leukemics, prolonged neutropenic acute leukemics. And we didn't have a lot of good anti-mold options at that time. Kanda and colleagues did a meta-analysis, looked at 16 different fluconazole trials. They were trying to look at basically which patients get the biggest benefit from fluconazole prophylaxis. They found, not surprisingly, even low doses in the 50 to 200 milligram a day range did, in fact, reduce superficial fungal infections for these patients. So there was a quality of life issue here. But it was not effective at reducing definitive invasive fungal infections except in very high-risk patients. And those were the trials where the risk of invasive fungal infection was at least 15%. And that's only going to happen in your acute leukemics with prolonged neutropenia or your stem cell transplant patients. Okay. So fluconazole definitely took on a role in antifungal prophylaxis following some of these studies. And it was low toxicity and very effective, very well tolerated. Itraconazole is another azole agent that we have that has a little bit broader activity, including some anti-aspergillus activity. So there was a lot of interest in looking at itraconazole for prophylaxis. Now, originally it was just available as an oral capsule with very erratic bioavailability. And then later in 1997, a hydroxypropyl beta-cyclodextrin solubilized formulation became available, a liquid itraconazole and then we briefly had an IV formulation of itraconazole available to us, and that had a much more reliable absorption than the capsules did. Itraconazole is hepatically eliminated, unlike fluconazole, and it's also kind of weird with the different formulations. Like the capsules need to be taken with food. They have a 63% higher AUC if taken with food, but the oral solution needs to be taken on an empty stomach. So when they actually compared itraconazole, 200 milligrams of itraconazole oral suspension versus capsule, and they gave each one optimally, then they found that you wound up with basically twice as, the area under the curve, the concentrations were about twice as high with the oral suspension. So the bottom line is, I wouldn't particularly care to treat a serious life-threatening infection or even try to prevent one with the capsules. The solution is superior pharmacokinetically. I do think it's important, though, to mention the downsides of itraconazole, and one that a lot of people are not aware of is there's a potential for congestive heart failure or aggravating congestive heart failure with itraconazole. So what we know is that in healthy volunteers, when they were testing the IV itraconazole, they would see a drop in left ventricular ejection fraction that would normalize by the time the next dose was due. So it wasn't considered to be clinically significant in healthy volunteers. But what we do know is that there have been 58 reported cases to the FDA of CHF developing on itraconazole, 28 hospital admissions and 13 deaths, and this hasn't been reported with the other azoles. So it's a black box warning on itracanazole's package insert, so just be aware of that. Other issues, get a lot of GI complaints with itraconazole, nausea, vomiting, diarrhea, abdominal pain. This is dose dependent, and it can actually lead to noncompliance. So I know at least one patient who wound up dying of aspergillus pneumonia who wasn't able to take his itraconazole oral solution because of palatability issues. Okay, hepatotoxicity is certainly something we have to monitor with all the azoles, and itraconazole is no exception. There have been some severe cases. So we have a couple. I'm going to highlight a couple of articles here. Dr. Marr, the same one who did this fluconazole study in the stem cell transplant patients, she wanted to look at itraconazole as well. And they had 304 allogeneic stem cell transplant patients. They randomized them to get itraconazole or fluconazole. And the itraconazole group had a substantially higher incidence of side effects, mostly GI, like 24% versus 5%, comparing itraconazole to fluconazole. Partly that's because you get more GI side effects with itraconazole than fluconazole. Partly it may be because you get different drug interactions with the hydrocyclophosphamide that I mentioned before. So instead of shunning away from toxic metabolites, you actually be increasing exposure to toxic metabolites with itraconazole, which only inhibits 3A4. So they found no difference in overall or fungal-free survival, although there was fewer invasive fungal infections during itraconazole therapy and fewer invasive mold infections with itraconazole, although the rate of candidiasis was similar between the two groups. Okay. So it's an option, but there may be some benefit for those patients who can tolerate it anyway. But a lot of your patients won't be able to tolerate it. Also, we have Pharm.D reported on a meta-analysis of 5 randomized studies of fluconazole versus itraconazole in a variety of cancer patients. And really, we're looking at neutropenic hematology oncology patients, mostly leukemics. And again, they found fewer adverse side effects with fluconazole. But they found more suspected and documented invasive fungal infections with the fluconazole group. So the overall risk, the risk ratio, odds ratio was 1.62, which did meet statistical significance. However, there were no statistically significant differences in documented invasive fungal infections, overall mortality or mortality attributable to invasive fungal infections. So it's only when they combined suspected with documented did they see a difference there. So it wasn't enough data really to make us say, well, my patients hate this drug, but I'm going to force them to take it because the results are so mind blowing. They really weren't at that level. But now when you enter some of the newer extended spectrum azoles, the dynamics change a little bit compared to itraconazole. So posaconazole, which currently is available only as a 200 milligram per 5 ml oral suspension, just be aware that there is actually a tablet in the works that may actually help us a great deal in terms of more reliable absorption of this drug. Also, there's an IV formulation that's being studied, so hopefully we'll have access to these new formulations in the not-too-distant future. But the FDA has approved posaconazole for the prophylaxis of invasive aspergillosis and candidiasis in high-risk patients, such as patients with hematological malignancies and prolonged neutropenia, and specifically was studied in patients with acute myeloid leukemia and myelodysplastic syndrome who received induction chemotherapy. Also in stem cell transplant patients who developed graft-versus-host disease, and vast majority of whom receive high-dose corticosteroids, which in combination with their other immunosuppressants certainly increases their risk of aspergillosis. It's also approved for treatment of oropharyngeal candidiasis, not likely to be used first line, although it can be used second line for oropharyngeal candidiasis that's refractory to fluconazole or itraconazole, and you want an oral option. A couple things about posaconazole that make it tricky. Posaconazole is absorbed in the stomach, right? So you need for optimal absorption, you need an acidic pH in the stomach. So proton pump inhibitors do not play well with posaconazole. It's going to substantially reduce your area under the curve. It can be as much as 20 to 40%, which can be clinically significant. We've found that now on the flip side, you can increase the acidity by taking it with ginger ale or cola because of the carbonic acid. And there are actually reports of using vitamin C, ascorbic acid, to increase the acidity to help with the absorption of posaconazole. We do know that posaconazole has satural absorption, and that it needs to be taken with food or at least something like a supplement like Boost in order to maximize its absorption. You get better levels with 200 milligrams 4 times a day than you do with 400 milligrams twice a day because of that satural absorption, although obviously there can be compliance issues when you start to give more and more frequent dosing of the drug. Posaconazole is primarily metabolized by UDP glucuronidation. It has no major oxidative or CYP-based metabolites. We don't adjust the dose for renal or hepatic insufficiency. And it will inhibit cytochrome P450-3A4. It's a potent inhibitor of 3A4, but only 3A4. And it has excellent distribution and a long half-life. So it's weird to have a drug with a long half-life, and we're to say we're going to give it 3 to 4 times a day. But that's that satural absorption issue hitting you there. Okay, So just kind of summarize the AML, MDS induction chemotherapy prophylaxis study. This is a randomized, multi-center trial, blinded evaluators, 304 patients randomized to posaconazole, 298 patients randomized either fluconazole or itraconazole. The center got to say, well, we're a fluconazole center or we're an itraconazole center. And what they found was the posaconazole group had lower rates of aspergillus and invasive fungal infection. And they had a statistically significant reduction in overall mortality through day 100 in the posaconazole group as compared to the fluconazole or itraconazole group. And actually, the fluconazole and itraconazole groups didn't actually look all that different when you really looked at that data. So this actually showed, remember that's a relative reduction in overall mortality, not an absolute reduction in overall mortality, but nonetheless, it was statistically significant and clinically significant. Now, when this was studied in allogeneic stem cell transplant patients with graft-versus-host disease requiring high-dose corticosteroids, their primary endpoint was reduction of invasive fungal infections through day plus 112, and they failed to show superiority of posaconazole over fluconazole using the primary endpoint. For secondary endpoints, they did show the posaconazole group had a lower aspergillus rate through 112 days. They also showed the posaconazole group had a lower invasive fungal infection aspergillus rate during the period of prophylaxis plus 7 days. And no difference in overall mortality between the groups, although there was a lower mortality from invasive fungal effects in the posaconazole group compared to fluconazole. So basically, part of this had to do with the fact they were able to show in the prolonged neutropenic patients, they were able to show a survival advantage as well as reducing invasive fungal infections. Here, they were looking at a set time period rather than the while on prophylaxis. So their data always looks better if you look at the while on prophylaxis than the set time period. So they might have changed their primary for secondary endpoints if they had known this was going to happen. But posaconazole, extended spectrum azoles can have benefits in these patients, but a survival advantage is maybe too much to ask for, particularly considering that these are complicated patients with many other causes for morbidity and mortality. Now, the other extended spectrum azole that we have is voriconazole, or VFEND, right? Available in tablets, 50 and 200 milligram tablets, and oral suspension, and an IV formulation. Voriconazole has some unique issues with it, right? So there's visual disturbances, like the rule of 30, right? So about 30% of patients will experience visual complaints. It usually happens about 30 minutes after the drug is administered and lasts for about 30 minutes. Some patients a little bit longer, patients a little bit less. It can improve over time. They tend to be relatively minor visual disturbances. They generally don't require discontinuation of therapy. And the site of action is the retina, and we can tell by retinography that these changes go away within 2 weeks of the drug being discontinued. So you can let the patients know it's not a permanent thing. Mostly it tends to be a lot of floaters, or I see a little bit of a halo effect around certain objects when they're at peak concentrations of the drug. On the other hand, and probably even more important to warn your patients about, is that hallucinations were reported at a higher rate in the voriconazole group when compared to amphotericin B group for the invasive aspergillosis treatment protocol, right? So they were using more aggressive dosing for treatment than we use for prophylaxis, but even at 200 milligrams twice a day, we have seen patients experience some very interesting hallucinations with voriconazole. Those are the patients who are poor metabolizers, who wind up with higher than necessary concentration of voriconazole, and it's very difficult. And you can't really spot that. So you don't really know who is going to be that patient who is not going to be able to tolerate it. The voriconazole is also a photosensitizer, so patients have to be warned to cover up, use good quality sunscreen if they're going to be on this drug for some time. Voriconazole has excellent bioavailability as opposed to posacanazole's satural absorption. It actually shouldn't be taken with food, so you should wait an hour before or after food. Its absorption is not affected by pH, but it has a more complicated metabolic path, right? It's metabolized by 2C19 predominantly, to a lesser extent 2C9 and 3A4. And you actually have to consider dose reduction in patients who have significant cholestatic liver damage. So there are actually recommendations in the PI if the patient has Child-Pugh score A or B to reduce the maintenance dose by 50%. And they note that Child-Pugh score C, it hasn't been studied. To mention that Child-Pugh score is based on chronic liver failure and doesn't really fit some of our oncology patients who may have acute liver dysfunction from their chemotherapy. So we'll talk about, I'm generally not quite this aggressive at dose reduction when I'm treating especially. The half-life is significantly shorter than posaconazole, but is concentration dependent. So you have saturable metabolism with voriconazole. So the higher the concentration, the longer the half-life, much like phenytoin. Okay, so voriconazole has been looked at for prophylaxis in the allostem cell transplant patient population, but the study was different than the posaconazole study. This study by Dr. Wingard and colleagues looked at 600 standard risk allostem cell transplant patients. So they started voriconazole when the patient came in for their transplant and continued it, and they randomized that versus fluconazole and continued that through day plus 100 or 180 if the patient had GVHD or a low CD4 count. And they were looking to see if frontline anti-mold prophylaxis in these patients would reduce fungal-free survival. So when you look at 6 months, the cumulative rates of proven, probable, and presumptive invasive fungal infection is like 10.6 versus 6.6, not statistically significant. At 12 months, clearly not statistically significant. There's no difference in fungal-free survival between these two groups at all. So voriconazole is not superior up front for standard risk allogeneic stem cell transplant patients. Now, the risk of aspergillus as of 6 months was there were 16 patients in the fluconazole group versus 7 voriconazole group. P-value was 0.05, which might be a little bit of data dredging at that point. Certainly, fluconazole has no activity against aspergillus, and voriconazole does. But the primary endpoint, this study didn't suggest that you needed to use voriconazole frontline. Now, we at Moffitt had looked at, we actually started using voriconazole prophylactically in our acute leukemics with pulmonary neutropenia. Prophylactically, before, beginning like in 2005, before posaconazole was even on the market. So we knew we had a high-risk patient population, and even before the posaconazole data was available, we suspected that these patients would benefit from anti-mold prophylaxis. So voriconazole was available, that's what we gave them, right? So we were using, and we've also continued to use it in our acute lymphocytic leukemia patients who were getting vincristine, because with the shorter half-life, we could stop the vori for a couple days before and after each dose of vincristine and avoid the drug interaction. Also, patients who had poor PO intake were unlikely to get good absorption of posaconazole, but voriconazole, either PO or IV, would be a solid option for them. So we retrospectively reviewed our experience with both agents and presented that at ASH in 2008. And we compared 129 patients who got voriconazole versus 66 who got posaconazole. Baseline characteristics were similar, comparative median days of neutropenia, and comparable incidence of proven or probable invasive fungal infections, 7 versus 6%. The median time of prophylaxis was comparable. The adverse effects requiring discontinuation were different, but the incidence was comparable. Now, maybe we weren't quite as quick to take the patients off voriconazole back then because we didn't have posaconazole to switch to, but so our experience was that voriconazole was another option for anti-mold prophylaxis in that high-risk patient population. Okay. So every now and then, though, you're going to run into patients who aren't candidates, right? There are contraindications that we have to consider, right? So number one, you'll hear about anthracyclines. Okay, in the posaconazole study, they said no posaconazole prophylaxis for during anthracycline administration and for 24 hours after. Okay, this was a theoretical concern because anthracyclines, like daunorubicin, can occasionally cause acute arrhythmias. It's pretty rare, but it can happen. And azoles can cause QTc prolongation, which can cause ventricular arrhythmias. So could there be an increased risk of giving them at the same time? Anyway, there was a prophylaxis study, so they better safe than sorry, and they made that rule. Now I hear people saying, well, I can't give this voriconazole in combination with the anthracycline, even though they've got a big old aspergilloma on their CT scan. I'm like, no. You know, risk versus benefit. Come on, guys. But if it's prophylaxis, sure, you can wait a few days to start your prophylaxis. If it's treatment, the other thing to be aware of is that you have, you know, posaconazole inhibits 3A4, voriconazole inhibits 2C9, 2C19, and 3A4. Lots of 3A4 substrates amongst our chemotherapy agents, right? So cytotoxic agents like vinca alkaloids. So vincristine, if you inhibit that, you can wind up with severe peripheral neuropathy. Busulfan, you inhibit that, you might wind up with veno-occlusive disease of the liver. We already talked about interactions with cyclophosphamide. Ifosfamide is bioactivated by 3A4, so you may actually inhibit the efficacy of ifosfamide. Taxanes and etoposide are 3A4 metabolized. Many of the tyrosine kinase inhibitors are 3A4 metabolized, such as Gleevec, imatinib, dasatinib. High-dose cyclophosphamide is occasionally used as part of a chemotherapeutic regimen, and that's a major 3A4 substrate. And we also encounter people who have pre-existing QTc prolongation or pre-existing liver dysfunction that makes us nervous about using extended spectrum azoles. Okay, shifting gears to micafungin. So a kinase antifungal inhibiting beta-1,3-D glucan synthesis, fungicidal versus Candida, fungistatic versus Aspergillus. Drug interactions, a little bit of a bump in sirolimus AUC, a little bit of a bump in nifedipine, but otherwise not a lot of drug interactions here. It's actually FDA approved for prevention of candidiasis in patients receiving stem cell transplant, and this was a randomized double-blind trial with 882 patients. They randomized people to get micafungin 50 versus fluconazole 400 a day from the start of chemotherapy until their neutrophils recovered. And what they found was that 81% of the patients who received micafungin met these criteria for successful prophylaxis versus 74% for fluconazole. This was statistically significant, but arguably maybe not clinically significant. The breakthrough infections, 1.6% in the micafungin group, 1 Aspergillus, 4 Candida, 1 Fusarium, 1 Zygomycosis, versus 2.4% in the fluconazole group, mostly Aspergillus. 1 case of death in each group, zygomycosis breaking through micafungin, and 2 cases in the fluconazole group associated with pulmonary aspergillosis. So kind of like the voriconazole study, this may not be enough to say you have to use micafungin prophylactically in the stem cell transplant patients, but it's an option, and it's an option when you don't want to, say, inhibit cyclosporin, tacrolimus sirolimus metabolism in the midst of this. Conventional amphotericin B, or amphotericin, that we've been using since the 1950s. Fungicidal, broad activity versus yeasts and molds, but toxicity profile obviously is the problem. Fevers, chills, rigors, anaphylactoid reactions, nephrotoxicity, potassium magnesium wasting, and yet this drug has been looked at for prophylaxis. Low-dose IV amphotericin B, there was some interest in that, particularly before some of these other extended spectrum azoles came out, right? But this was reported by Wolf and colleagues 2000. And they had 355 stem cell transplant patients, a fourth of them who were allo transplant patients, getting very low-dose AmphoB, 0.2 mg per kg per day versus fluconazole. And they saw, unfortunately, what they saw was no significant difference in proven fungal infections, and they saw amphotericin B prophylaxis had to be stopped more commonly because of side effects, mostly nephrotoxicity. So giving IV amphotericin B, even at low dose, is probably not a great prophylactic strategy. However, nebulized amphotericin B has been studied in allogeneic stem cell transplant patients with graft-versus-host disease in order to prevent invasive pulmonary aspergillosis. And they did see a reduction, 2.5% versus 6.6% compared to placebo. And they had one instance of breakthrough aspergillosis out of 111 patients who got nebulized amphotericin B. Now we have the more modern, the lipid formulations of amphotericin B, and the one I'm going to be talking about briefly is liposomal amphotericin B, or ambisome, because that's where we have some data. And there's an interesting study that was published in 2006 by Penek and colleagues. Small numbers, 132 hem-onc patients with greater than or equal to 10 days of neutropenia, but they randomized them to either get liposomal amphotericin B or placebo. And this lipid ampho B that was a very low dose of 50 milligrams every other day. Considering that we use like 3 to 5 milligrams per kilogram per day when we're using it for treatment, this is a very small dose. It was quite well tolerated. And there were fewer proven and probable invasive fungal infections seen even with this low-dose lipid amphotericin B. Looking at the first neutropenic episode, it was 6.7% versus 35%. All the neutropenic episodes, 4.6% versus 20.2%. This makes me think, wow, I don't know how ethical it was to give placebo to patients with a 20 to 35% risk of invasive fungal infection. But so when you look at the frequency of aspergillosis, this was really where the low-dose ambisome was effective. Where it wasn't nearly as effective was in the reducing the frequency of candidiasis. In fact, it was not statistically significantly better than placebo. So, when we look at this data, we think, honestly, probably the dose was too low. If all you're trying to do is prevent invasive pulmonary aspergillosis, this is great. But if you're also trying to do at least as well as fluconazole at preventing candidemia candidiasis, this doesn't look as good. And once in a great while, we've been known to give ambisome as prophylaxis, but we've generally used a little bit higher dose, more in the 1 milligram per kilogram range. But there's not specific data for prophylaxis with that, although there is some very early data about treatment with that. We do occasionally use liposomal amphotericin B nebulized, though. So this was a study that was published in CID in 2008 by Ringers and colleagues. 271 hem-onc patients, again with greater than or equal to 10 days of neutropenia, 407 episodes. They're randomizing people to get liposomal amphotericin B, 12.5 milligrams twice a week, or placebo. And they showed a reduction of invasive pulmonary aspergillosis down to 2.2% versus 13.4% in the placebo group. And they really had no serious side effects. They had a higher incidence of cough in the nebulized ambisome group. Okay, so just to kind of try to pull this all together, this is copied from the National Comprehensive NCCN, right? National Comprehensive Cancer Center Network guidelines for prevention and treatment of cancer-related infections. So this is a really useful set of guidelines available at nccn.org. And they're looking at antifungal prophylaxis and looking at patients who are at intermediate to high risk. So which patients get the biggest benefit from antifungal prophylaxis? And do they need anti-yeast or anti-mold prophylaxis? So for our acute lymphocytic leukemia patients, fluconazole is recommended predominantly. We will occasionally use an anti-mold prophylaxis in those patients if they're neutropenic prior to admission. So they're actually more prolonged neutropenic, more like our AML MDS patients who should get anti-mold prophylaxis. So posaconazole or voriconazole. They mention amphotericin B products as an option. Autologous stem cell transplant patients, if they don't have mucositis, they may not need fluconazole at all. If they do, fluconazole works. For allogeneic stem cell transplant patients, you want some antifungal prophylaxis, but it can be fluconazole, it can be micafungin, it can be itraconazole, voriconazole, posaconazole. Take your choice. If you have a patient with allogeneic stem cell transplant with significant graft-versus-host disease, those patients do benefit from anti-mold prophylaxis. So you want an agent with anti-mold activity, such as posaconazole or voriconazole. There's less data with echinocandins. So really it comes down to knowing your patient population, what is their risk for candida infections versus mold infections, and your general choice. The azoles are going to be your major workhorse, but when you have some patient with a elevated QTc on amiodarone, or you have a patient who already has substantial liver dysfunction, or there are other unmanageable drug interactions, as much as we try to manage them, such as dronabinol, which is an absolute contraindication for azoles, or the study won't let the clinical trial won't let them be on azole while they're getting their study drug, or they just absolutely cannot tolerate them. We may have to look at some other options. So, are there any questions?
So, Rob, would you say this is the best source in terms of a summary of prophylaxis for antifungals for people to kind of keep in their smartphone or back pocket or what have you?
Yeah, no, I would. I mean, I think when it comes, so like comparing the Infectious Disease Society of America guidelines for fever and neutropenia and the NCCN, I think that the IDSA guidelines are excellent now that they've finally been revised. Thank God. However, they will look at prioritizing patients' risk, based on anticipated duration of neutropenia. Whereas like the NCCN, because it's for oncologists, it's like, okay, we're going to help identify which of your patients are likely to fall into these different categories, right? So, so like the patients with acute lymphocytic leukemia, for example, are not neutropenic as long as the patients with acute myeloid leukemia in the vast majority of cases. Again, if you've got your bone marrow so crowded with leukemia that you're neutropenic before you even get your chemotherapy, that's a higher risk scenario, obviously. But I think actually the NCCN guidelines do a nice job of breaking this down. But when we run into where we have to get creative and have to look at some of these other options other than voriconazole or posaconazole or fluconazole, are those patients, those complicated patients who have significant contraindications to the azoles. And we do encounter that, and it's also a risk versus benefit decision, right? I mean, and we've actually, we're currently using in these high-risk patients who cannot receive an azole antifungal, as our general prophylactic strategy is micafungin in combination with the inhaled ambisome, right? Because we want an agent that has activity to prevent candida, but we also we're not sure that that's adequate given the static nature, since it's only fungistatic activity. And note that micafungin is not approved for the prevention of aspergillus because there weren't enough. It was studied in a patient population where there wasn't a high enough incidence of aspergillus, during the initial neutropenic period of stem cell transplant, both autos and allos mixed. So, for extra anti-aspergillus activity, we'll actually give the twice-a-week ambisome nibs in combination with the micafungin. Again, if we cannot have the patient on an appropriate extended spectrum azole. Thanks for your attention, guys. It was a pleasure.